Okay, guys, there's been some really good questions the last few days about how this translates into clinical practice. So myself and my colleague, Preet Singh, came on the workshop in 2010 and then 2011, and we went away with a bit of curiosity and started thinking, well, does this really work? Obviously, Pete's an expert. He spends a lot of time with patients, and it's not really reflective in terms of clinical practice, where we're seeing patients in the NHS for 45 minutes appointments and even shorter follow-ups. So we decided to plan a service evaluation and have a look at our outcomes. And really, we wanted to know if we could implement CFT into our routine practice. And the objective really was to evaluate our outcomes of CFT on disability and pain in people referred to the physiotherapy service. And we then performed like a retrospective evaluation to look at the outcomes between pre and post CFT. And we were particularly interested in kind of pain and disability. Once we got the data, we then performed a statistical analysis, and we also wanted to see what the effect was on the clinical significance with patients. So I'll walk you through the stats in a little while. Also, we wanted to calculate the effect sizes just to see if we could compare our data to what's out there from other randomised controlled trials. So what did we do? Well, basically, we included every patient that we saw with low back pain with somatic referral, everybody the age of 16. They had to have an Oswestry Disability Index of more than 14%, and a pain score of more than 2 on the VAS. So it's quite a wide kind of inclusion criteria. We excluded people for obvious reasons with red flags, people in the acute phase, so pain less than 3 months, anybody with specific causes, stenosis, spondylolisthesis, and so on, any patients with pelvic girdle disorders, and anybody with pathological psychiatric problems. So that left us with 61 people to include with non-specific low back disorders. We found a small group who had centrally mediated pain problems like we were discussing this morning. And we then had 54 with kind of this peripheral nociceptive drive of their pain problem. So let's have a look at the baseline characteristics. So we had 61. The split was kind of 45% or 46% for males and 54% for females. Mean age was 47. The disability level, the mean Oswestry Disability Index was 35%. Mean pain score was moderate at 6.3, and the Erebro musculoskeletal pain questionnaire was 108 on average. Okay, so we can see from this data that they're a highly disabled group. Those who use the Erebro will know that anything a cut-off over about 105 suggests that the patient potentially is a future risk for long-term work absenteeism and future chronic problems. So we were really pleased that we got a group that we could intervene with. In terms of how this separated out in their duration of pain, I think it's really important. They're roughly into thirds, but again, 30% of these had this for more than 5 years, and I think our maximum statistic was 40 years. So some people had this a long time. Employment status, 60% were working. A smaller group, 13% were unemployed. Are the ones who were off work when they came to see us but were employed, they all went back to work by one patient within the time frame before they were discharged. So how did this all kind of pan out? What were the results? So our mean disability level to begin with was 35.7 on the Oswestry, and then post-treatment reduced to, on average, around 11. Okay, so quite a big change. For pain, 6.3, like I said at the beginning, and then immediately at the end of treatment, it reduced down to 3.3, so a 3-point change in pain. So just to kind of highlight a little bit further, there was a kind of 24.5-point change in the Oswestry Disability Index. The Erebro, and again Peter touched on this yesterday, is we found it very responsive to change, as it's not meant to be used as an outcome measure, more as a screening tool, but we can see we had a 40-point change, so they went down from 108 into the 60s. And then, as I said, a 3-point change in pain. So from a statistical perspective, they were all highly significant on a P001 level. And I think what's really interesting, what we'd like to point out, is that the subscales of the Erebro questionnaire, as I said, were very responsive. So the big drivers of pain and disability seem to change as well. Okay, so depression, stress, anxiety, catastrophizing, fear of movement, fear of work. Okay. So that's all good and well having statistical significance, but how does this map out clinically? So we decided to have a look and compare this to the industry standards, if you like, from the Cochrane collaboration, and looking at what really means, a clinically important change for pain and disability in this group. So we use a 10-point change for disability, and we use a 2-point change or more for people with pain. And you can see clearly there that 88% of our cohort achieved a significant reduction in their disability levels, and 75% achieved a significant reduction in their pain. So we need to put that in some kind of context, how this kind of maps to kind of local services within Leicester. So I was very fortunate to be able to get hold of some data from one of the local hospitals in Leicester, where they use traditional kind of physiotherapy methods, manual therapy, education advice, exercise, some cognitive behavioural principles, plus the additive of a back class. And they had a similar number of patients. There was 43 within this group. And what we found was a 5-point change in the disability levels using the Oswestry, and a 0.7 change in pain. I didn't get the exact number on treatments. This was data analysed a few years ago. But they had a minimum of 8 sessions of the back class, and they would have had a minimum of 1 appointment with the physiotherapist's initial consultation. How does that compare? Well, CFT had a 24.7 change in the Oswestry, a 3-point change in pain, and this was done on less treatment, so 5.9. So let's think about the context in terms of calculating the effect sizes. So the data analysed for the physiotherapy and the back class for disability levels were 0.34, 0.39 for pain and disability, so small effects, and there was no effect on the Tampa scale of kinesiophobia, so no effects on fear. I think it's really important to acknowledge the work of Jonathan Hill at the Start Back approach up at Keele. And again, just to look at the effect sizes from the Start Back, they were a little bit higher for the medium and high risk groups, so they're having a small to a moderate effect. But at 12-month follow-up, the effect seems to diminish, and I think this has been touched on this week as well, where we can deal with the cognitive bits, but when we're not integrating the functional aspects within the patients as well, then it is probably not having the profound effect that we desire. So the effect sizes for CFT in Leicester were huge, 1.56 for disability and 1.21 for pain, so a big difference. What are the limitations? Some people say it's not research. We've put this together as a service evaluation just to see how this shakes down in clinical practice. There's obviously an element of bias for 2 physiotherapists employing this approach. We tried to mitigate for that with actually looking at every patient that we'd seen over the previous couple of years with non-specific chronic low back pain. We don't have any long-term data at the moment. This just represents kind of the end of care on discharge, but we were very fortunate last week to be granted permissions by our governance leads in the hospital to approach patients to get some 12-month data follow-up. So hopefully, if you guys are back here in a year's time, we'll be able to give you a little bit more feedback on that. So it does limit our generalisability of this, but I think there are a lot of strengths to consider as well. These are a highly disabled cohort, so really high disability levels, and it's just a reflection of our routine clinical practice. And we've not been specifically trained by Peter in this. We've attended the workshop on 2 occasions and just seen how we can apply this to our practice. And it seems that we're getting a very good effect with our treatments. So just to summarise, is that CBCFT resulted in statistically but also clinically significant improvements in disability and pain for this group. It produced outcomes that are superior to those previously reported locally within the service, and also in comparison to those generated by the research literature. So we kind of conclude that it's effective in the management of non-specific chronic low back pain, and it can be successfully implemented into a physiotherapy service. And I think that's probably some of the kind of questions you guys have got, is can we go away and do this? And my kind of parting comment to you would be, go away and do this. You know, it's so rewarding for your practice. It can be done. Yes, you probably will run over with patients, but I think the outcomes speak for themselves. We'd love to hear from you. Anybody's got any experiences and patients who'd like to chat about this data, then get in touch. There's our email addresses there, and we'd be happy to chat. Thank you for listening.